I don't see any other questions related to this past group. Is there anybody who wants to get to the microphone before I move on? Okay. So this was helpful because I think it'll stimulate some of the comments that each of you will make, which we will then use for further discussion tomorrow and thereafter. So I'm going to ask the members of the roundtable if they would come up one by one as you would like, and just give 1 or 2 points of reflection that you have on today's meeting. This has been a long day, so I'm sure by now there have been some thoughts that each of you would have. And again, we can go further with those tomorrow, but let's at least have the roundtable members come up with just 1 or 2 reflections on the day's discussion. Go to it, Katina.
Katina O'Leary, Health Literacy, Missouri. 2, I think, really simple thoughts for me today. 1, this first conversation that we started the morning with to some degree about the business case or the ROI or whatever we want to talk about. Frankly, we've been struggling with this for 6 years in Missouri. We've been funded primarily by the Missouri Foundation for Health, and as everybody in this room probably knows, that kind of line of funding is shifting pretty significantly, and we have to figure out how to be sustainable. And as a function of that, we've built, as a function of the funding from MFH, we've built a structure that's fairly hard to sustain without a pretty significant inflow of funds. And so this business case we spend a lot of time on, and I was sitting there in Missouri thinking I was the only one who couldn't figure it out. So it's really good to be here and hear that nobody else has the answer yet. And we kind of put it in a little box over here and said, that's okay, we can't figure it out either, and maybe we shouldn't be talking about it, sort of. And so I just want to put a plug for really paying some attention to that as a roundtable and figuring it out together so we can all tell the same story. It would be really nice to have at least one story that we kind of all felt good about and we felt strongly about, and we put the pieces of research and policy and all those things together so we could speak in the same language over and over again and at least not compete against each other in that way. And there is one story here somewhere, and it would be nice to kind of figure that out. And then the second thing is I'm having a little bit of dissonance maybe here. I really expected to hear a lot of people here today, a lot of people's stories, and I feel like I heard a lot of stories that were about kind of funding and initiatives and policy and things like that, and so I'm just trying to figure out kind of where I sit on this idea of language and access and all this stuff, culture. I don't feel like I heard as much as I thought I was going to hear about it, and I'm not sure if it's because the disciplines are still in their infancy and we're trying to figure it out, or I didn't know what I was hearing, or what that is. But I guess what I would say is maybe we're not done with that conversation either, because there's really a lot here about the people part that I think we could still talk about. Thank you.
Michael?
I'd like to echo some of Katina's thoughts there. We've been in this situation with an inequity in our healthcare system for years and years. We've had policy, legislative, regulatory, payment reform sorts of approaches to this, and we've moved the needle a little bit here and there. But we're essentially not, and this is just my own opinion, we're essentially not a whole lot further down the road toward a state of health equity in this country than we were before. So, Andrew made the point about, stories are what win over people's hearts. And Bernie, you made the point about bold gestures are the things that really move the needle. And maybe it's time for us, and maybe the bold initiative of this roundtable would be to engage and activate that segment of our population that is most affected by this, and that's where we're going to get our stories. That's where we're going to get our action. We have mechanisms in place now in the marketplace where people rate the places that they go to. Consumer Reports, Angie's List, Yelp. We make votes there, and if it's a terrible business, they get a low vote, and if it's a great business, they get a great vote. And people tend to go to the places that get the great votes, and so there's a great power here, I think, that we can engage and activate that would start to move us toward that. We don't need to, prescribe how that happens. There's an awful lot of great community-based programs that show wonderful solutions to how we can level the playing field and bring everybody in and provide language access and provide culturally competent care for everyone and provide those services in a health literate manner. Let's take a look at some of those programs and let the people who are providing the care figure that out. Let the marketplace figure that out. I mean, that's who we are as a country, that we allow this notion of competition and letting the good practices bubble up to the top. So I think there's great power there, and I think we may be able to find a role for the Roundtable to play in that.
I'm just going to ask that we go from one microphone to another to make it easier.
Lori Hall from Eli Lilly and Company. I'd like to make a comment around how do you operationalize LLC. And I'm particularly interested in implementation and sort of the boots on the ground perspective. That's the world that I live in. And my job when I leave the Roundtable is to collect all of the nuggets, the pearls of the information I'm hearing from the research perspective, from the policy perspective, from the academic perspective, and then try to boil that down and give it legs and make it implementable across an organization. So I'm wondering, we often, in my organization, we spend so much time analyzing that we become paralyzed, right? Analysis paralysis. So I start to think about what are the few things that could start to get the ball rolling. And I think, we look to often examples that we use with people, patients, the Ask Me 3 campaign, for example. What if there was a similar campaign for providers as a way to help give them just a couple of tools, just one or two tools that they could implement immediately? Try it with one patient a day, a couple of patients a day. Something that would be a repeatable message that you can memorize pretty quickly. But it starts with that. It starts with small steps, and small steps start to become behavior change, and with behavior change we start to see results. So maybe it's something around really providing a few of the building blocks of good communication, which is always begins with active listening. So maybe it's 3 questions like, what is your understanding of your condition? How do you feel about what we've just talked about? What questions or concerns do you have? Some sort of, almost a marketing spin around it, but something, a campaign that's memorable, that perhaps it's even funny, but something that could be quickly and easily disseminated so that providers who are so overwhelmed with so many competing priorities could have this as a quick tool that would actually get the ball rolling, that honors all people. And that really is the foundation of all of good healthcare, is that everyone feels recognized and heard and appreciated, and that their opinion matters. So I think that's a universal theme, and I think there might be something to that. We talked about low-hanging fruit earlier, and I think that could be a place to start.
Terry Parnell, Health Literacy Partners. One of the first things was a little bit earlier today, and it was around the concept of the social noise, which I have to say I haven't in the past given much thought to. So that's sticking with me a lot, to give more thought to that and what a difference that could make in that relationship and that communication. I think when we're speaking about leadership and metrics and data, really changing our perspective, and I know some of us and have done this, but instead of from an administrative or an organizational or health system point of view, a lot of the data that's given on a daily basis, as many of you know, it's, what's the census, how many falls, OR start times, things like that. And what if we flipped that perspective more consistently and looked at, from our electronic medical record, teach back, how many, patients had teach back done that day, or plain language, or with language access services, what was the connect time for that. How long were they on the call? What was that person's experience? Are we evaluating that? And just really flipping the metrics around health literacy, language, and culture. And continuing, I feel it's very important to continue to break down the silos that sometimes exist around LLC. It's in order to operationalize that effectively and sustain it, we need to break down those silos. And the other thing that just keeps coming back to me all day is that book that was written by Ann Fadiman, The Spirit Catches You and You Fall Down. I mean, I just, all day today, I've been thinking that, and I have to probably read that again for about the 10th time, but I think that illustrates everything that we're speaking about today. So, thank you.
All right, Chris Desi, Bristol Myers Squibb. I'm an advocate for provider and plan and part of this patient accountability. The only way I know to hold people accountable is to measure something. I got beat up a little bit again, but that's all right. I'll get beat up tomorrow on suggesting, what gets managed gets measured and reimbursed. I happen to think that there needs to be incentives to allow all these wonderful things that we are talking about to happen. I don't think Adam Smith's invisible hand is working. I don't think it's doing it. So I'm big on, somebody mentioned mandate. I happen to think performance measure. What matter of shape? I mean, the point about the outcomes, I appreciate, but I think absent the nexus of the inputs of, or the impacts of cultural competency, health literacy, into that equation that leads to the good outcomes, will get those things used. Well, if you know what I mean. That's it, and you'll hear me again tomorrow.
Rob Logan, National Library of Medicine, which is part of the National Institutes of Health. I was listening when some folks said earlier today that NIH should better support cultural competency, language access, intervention research, and support the creation of a more comprehensive evidence-based and best practices. I was listening when some folks said NIH should support more research that demonstrates a return on initiative or return on investment from intervention efforts and comparative effectiveness research. I'll mention it in future meetings where we collectively discuss funding priorities. I obviously haven't discussed it with my colleagues, but it's worth mentioning and it's worth discussing. I also remind you that there are other agencies, okay, besides NIH, particularly the Patient-Centered Outcome Research Institute, okay, that has to be taken in mind when we discuss these things. More specifically, here's what I'll really support. I'll support the creation of a home to support the integration of multidimensional research that addresses how to enhance assessment at all levels of measurement of health literacy, health disparities, cultural competence, and language access. How to enhance health literacy, health disparities, cultural competences, language access interventions, and how to encourage the diffusion of findings or their translation into practice. I think the Roundtable's role is to address the need for the creation of a research center with these goals in mind, those goals and objectives, as well as the creation, dissemination, professional diffusion of integrated, that's the key word here, health literacy, cultural competence, health disparities, language access, research, and practice. Finally, regarding the comments that Dr. Rosof made earlier, I'm all for a bold initiative, but I suggest it would be 10 times more effective if we got a group such as the Roundtable on Population Health to go in with us. That would be a dramatic, and that's, by the way, within the realm of possibility, okay? And I think that if we could get an ally such as them to come to the same conclusion, then I think we definitely will have a far more bolder statement.
Thank you for that, Rob.
Throughout the day, I've been thinking about strategies, and there are different themes that have emerged. I just want to mention them. They're not in a particularly logical order. So one of the themes is one of discouragement and despair, which I was very moved by when Alicia spoke. Another was the call for Where is Your Anger by Michael P.O. Another was, a response to that saying, but we have our passion. And we sort of moved on, and our general strategy within the Roundtable over the years seems to be on what constitutes a logical, sustained effort and strategy, making the business case, speaking the language of the people that we need to do, that we need to sort of be in alignment with us in order to make change. And I'm wondering, because there were little references to Bernie Sanders, there were references to how is it that most Americans, a majority of Americans, when you look at the last election, are voting against their own best interest? What's going on here? Why does it finally occur to people that we might need to collect data on how many people are killed by the police across the country? We don't have that data. It was really the Black Lives Matter movement that did it. It was the Occupy Wall Street, no matter how we felt about it, movement that really got this issue of equity in the 1% in the presidential debates, that it was actually named. You know, maybe we do need to have more passion and more audacity, and perhaps we need a little bit more focus on the issue of social justice and truly make the values argument and not simply the logical argument of the business case. So perhaps we need to really examine the success or lack of success in the last several years and perhaps try a slightly different and more passionate approach.
Lori Francis, what she said.
Okay.
And I will add, operationalizing that idea. So I have actually a great story. I'm not going to tell it right now, but I have another short story I will tell. And I really appreciate Lori's comment about us asking questions instead of patients asking what's wrong with them, which I find absurd. So we asked 10 clinics in Oregon to ask 10 patients 3 questions. And they were about social issues, so connectivity, economics, and stress. And out of that, 5 of those 10 clinics changed their model to completely embrace the social issues people are facing. So I would say that that simple intervention of changing what's happened to you, how can I help you today, how can I serve you today, is very different and might take us a long way. We call that radical customer orientation in Oregon. And it's funny that it has to be radical, because Google figured that out a long time ago, as did Amazon. And then I would say the idea of operationalizing this process, and I really appreciate Marshall Chin's 6 steps. So I was looking at that in terms of operationalizing our plan over the next year or 2, and doing different dimensions of that. So there'd be a policy dimension, a care dimension, and a payment dimension, and perhaps a community dimension. I would call it the triple LC, listen, language, literacy, and culture, with listen at the beginning. And then I think that's it. Yeah, and put social justice at the beginning, middle, and end. Thanks.
Ernestine Willis, the Medical College of Wisconsin, what she said about listening, and I think that while I will make the premise that health status of many of our people really does depend upon those social determinants of health, and literacy, language, and culture is just one of the dimensions of social determinants of health, as far as I'm concerned. I think the discussion here is somewhat superficial, and we don't do the heavy lifting that we really need to do to hear from the people who are most impacted by the health inequities, as well as by the lack of engaging them in our process. The other concern I have is that we have so many systems and so many complex entities, and I was sitting here thinking, we talked about health communication. There's schools of public health, there's schools of health education, colleges, et cetera, throughout this country, and what impact are they having for the population and the many stakeholders that we have throughout this state is important. I do think we need to spend more time, and I appreciate this last panel because they were trying to give us some pointers on true action agendas and strategies of where we need to go, and I do think that's where we are. We know a lot, we have data, we still need to continue to collect data, but the data we have is data we haven't gotten, and we haven't gotten the data from the people who most impacted. I think the data we've gotten is from systems, big systems, and we've just seen today how that is not necessarily adequate. That secondary data won't necessarily help us to figure out how to operationalize what we need to do in a patient-centered, sensitive, and adaptable manner. That's it.
So Kim Parson from Humana, what she said, and what Rima said. And I'll just, two things that I'll take away, for us to think about. Culture is not just about race and ethnicity. And the other point that we need to be considering our culture. So when I say our, the industry, i.e. Payers, providers, pharma, us. And then Katina, in response to people, hearing from people and stories, and I'll give just a quick story of something that I heard the other day, and forgive me, I'm giving a physician example here, but you can insert payer, pharma, any in this example. So this physician was recounting serving the homeless for over 30 years. And initially, he had been in an ER and had seen a homeless man come in multiple times. And clearly, the man needed to be given treatment for some mental health issues. But they were having, the physicians in the ER were having no luck convincing him, to take the meds and to better himself this way. So the physician then started working at a clinic that served the homeless. And over time, the man that he had seen in the ER came to the clinic, and they had a conversation eventually. And it was the first time that he had ever heard the homeless man speak, even though he had encountered him many times in the ER. And so he asked him, when it comes to your health, what are you most focused on? And the homeless man responded that he really needed to get some sleep. And so through that opening, the physician was able to prescribe medicines for his mental health issues that also allowed this man to get some sleep. And not long after, he returned and said, I think it's working, but I think I need more. The homeless man's story then ended where he lived for over 20 years off of the streets in supportive housing and whatnot. But I would just give us that example when we're thinking about ROI and when we're thinking about culture and how we all show up and listening and conversations. There's your ROI.
Good afternoon. My name is Lindsay Robinson. I'm from the American Dental Association. I'm a pediatric dentist. And a few thoughts that I have. And first of all, I would like to underscore and ditto also, as well what Rima said earlier. And it reminds me of something she said when we were in the same room. It was our workshop on health literacy and public health. And in my thinking, the business case is more about a call to action. In something you said, it was a call to action because people are dying here. I mean, that should be the motivation, is that we can make an impact. I mean, look at the stories that we have just in the last half an hour have come up, and the stories from the patient or person perspective, the stories from the provider perspective. Clearly, if we put our heads together in a focused way, I think in terms of the big picture, Surgeon General's report highlighting the importance of health literacy. Also, I think it needs to trickle down into all segments of the healthcare system, whether you're talking about professional education, policy, funding. It all needs to be aligned. And that's what I'm taking away from this meeting today. Also, I'd like to just mention about the nesting doll slide that some people maybe don't relate to, but I really appreciated that slide, Michael, in different ways. Coming from a healthcare profession that has been traditionally siloed, the mouth from the rest of the body. So from dentistry, dentistry's been siloed from the healthcare system. I think there are opportunities to look for ways that we can be mutually supportive of each other in terms of literacy, language, cultural competency, consistent messaging to, it's about listening to the person, patient, and supporting their self-efficacy, and whether they're in a dental chair or in a medical office. There's so much we can do, and there's so many opportunities there. So, and I'll be talking more about that tomorrow.
Good afternoon. Jay Duig, AbbVie, Office of Patient Safety. So I believe, unless somebody's jumped in, I'll be the newest member of the Roundtable. So, first and foremost, this has been a terrific day for me to be here, to participate. It's wonderfully exciting to be joining yourselves in this effort through the Roundtable in the advancement of these issues today on health literacy, LLC, so in the overall science of patient safety and in improving care. So this is just a tremendous group of professionals, so I very, very much appreciate the opportunity to take part. So in going through this, and it's fun because you get your day job and then what you can really work on and be excited about. So I'm writing notes throughout the day, and a couple of things that struck me was that systems level of approach and how we can get together from all these different functional and professional areas to take that on. Dr. Rudd, you mentioned something that struck me with, we need to know more about the patients. We need to know more about who they are, what they do on their own terms. And I'm like, okay, so if that's a starting point of developing a greater knowledge base and also taking on, Dr. Wolf's questions about having all the different tools that we've already known through the research that's been done on health literacy and LLC and how those are potentially applicable, building into research questions like that Dr. Parker brought up of saying, who's investigating what, what's the value, and putting all these things together. So questions that I want to get more into and work more with the group in is what does that systems level approach look like and what can be brought in from systems research. If we look at like other systems research on consumer products like iPhones or anything else, there's such a tremendous turnover because there's access to the end user that gets immediately put back into a feedback loop because people have all these different choices of what they can do and where they can go, and that there are choices that will eventually win out in moving the technology forward. Healthcare in the US and often abroad, so it doesn't have that same type of market pressures that can direct things, and also with the regulatory needs. So I think that's a change in that end feedback loop that's very necessary and gets at those systems questions, again, as you said, Dr. Rudd, so of knowing more about people, so, and what they're doing and what's going to work for them. So I think it's very important if we can look at that loop of user-centered design and how to take those on, and in particular, how can we make incremental changes? That's a key point that's often very difficult, that you can't hit a home run on every pitch. You don't win the Nobel on every research paper, but you get a little bit better. You advance the science, and that can be so difficult to do in this space, particularly when we're talking about from a group like this, so of making these large policy initiatives of saying, because there's always going to be holes with something. You're never going to have something that's perfect. That's really what I got around our discussion today when trying to summarize, so, all these ideas from these wonderful professionals, how are you going to get all that in and something that's going to work for everybody? But building with that, with more the focus on how can we get a little bit better, so in these areas, and make that continual process. Well, thank you again. I appreciate being here today.
Wilma Alvarado-Little, IOM Roundtable member, and Alvarado-Little Consulting. I just want to, again, thank everyone for today, and the IOM for providing the opportunity for us to discuss this. And I don't want us to lose sight of some of the resources that have been really instrumental, at least from the language access perspective, to continue to move forward with the work that we do, and that being the Affordable Care Act, the class standards. And I want to thank Guadalupe Pacheco under his tenure with the Federal Office of Minority Health, really was a voice for us. And also the 10 attributes. I've had a really bad headache today, folks, and that light over there wasn't really helpful, so I apologize. So anyway, one of the things that I want to talk about too is the areas of research within our communities. You know, whenever I'm working with researchers and they start talking about, what I used to call the IOM-10, cancer, diabetes, asthma, obesity, they would point to the Black and Latino community because, we're researched to death. But one of the things that I want to put out there is the research studies themselves sometimes do not include individuals whose primary language or preferred language is English. So I'm not exactly sure how information is being captured regarding these other illnesses or diseases from a population who is not included in processes regarding research in their preferred language. Sometimes what I hear is, well, it's too expensive to translate that into different languages, or I don't know if we can get an interpreter to participate in the study. Well, having been hospital-based and having translated documents for the IRB and having interpreted those documents and participated as well, there's a way to do this. So if we really want to capture some of the information, I think we need to consider including individuals whose preferred language is one other than English. And I think that also would include our individuals who are in communities that belong to the deaf and hard of hearing as well. So just a consideration, if we're going to talk about research, let's do it where it's inclusive and not just convenient.
Okay, Andrew Pleasant, Canyon Ranch Institute, and it might be foolhardy, but I've decided to take on the depression and pessimism. It seems to be spreading today. And you can only talk about what you know. So I'm just going to actually tell you some stories about real people in the real world with positive outcomes because of the power of health literacy and addressing culture and addressing language. So we at Canyon Ranch Institute, for example, have a program that we have hosted for years now in multiple cultural settings, in multiple languages, in multiple regions across the United States, both rural and urban, Spanish and English predominantly. African American communities, Hispanic, Latino communities, communities mainly from the Puerto Rico, communities mainly from Mexico and Central America, with the same health literacy-based approach tailored to each community. Now, in our view, health literacy tells you to do one thing: engage people early and often. And if you do that, you will learn about them. You will learn about their history, their family, their mothers, their fathers, their grandfathers, their grandmothers, their parents, their children, the children that they don't have yet that they want to. If you listen, they will tell you. And that means that you've inherently taken an integrative approach: mind, body, spirit, and emotion. It is all four. It is not just the three, as many people often usually say. The emotional aspect of this is real. If you do that, and I don't care what healthcare profession you might have been trained in, it doesn't matter. If you do all of that, you've immediately taken their lives into a preventive mode instead of a sick care mode. And you're helping people turn around their life before they get sick, or you're helping people, and we have seen this numerous times, people who are type 2 diabetics coming into the program through lifestyle management have gone off medication and technically are no longer type 2 diabetics. Their blood levels have dropped that much. We've seen C-reactive protein drop 30 to 50%, a marker of inflation across the body. We've seen people who came in suicidal leave the program with a whole new outlook on life, take on a new role in the community, their civic engagement. Think about that. A health literacy program is improving civic engagement across cultures. So people are more active in their community, they're becoming teachers, they're going back to school, and they're helping not only themselves, but their friends, their family, and their community make changes in their better health. All of this is entirely possible with the things that we've talked about today. It's not enough to sit around and study what people with low health literacy don't have in their life. What are you going to learn? The same thing we've known. So it would be very easy for me to sit here. In fact, I texted somebody, yep, cultural competency, heard the same thing 20 years ago. Because that's still true today, about today. But it doesn't have to be, right? It doesn't have to be doom and gloom. It doesn't have to be pessimism. The tools we're developing are incredibly powerful. The one real barrier we all face, of course, is this perverse payment program. So can I prove the value of those changes in those people's lives? Absolutely, because we do it every day. Is the valuation perfect? Of course not. But is it darn good and good enough to make comparisons so that we could say to the payer system, you're reaping these benefits, but you didn't do anything to sow them. So how about sharing some of that savings with the people? And then you move into a situation where one of our partners, Urban Health Plan, can take the time to say, we're going to do something about the food desert in our community, because that's one of the biggest determinants of health. So imagine this, the CEO of an FQHC in the poorest congressional district in the United States goes to neighborhood stores and say, I want you to start selling fruits and vegetables, and if they don't sell at the end of the day, I'm going to come buy them. She had to buy them for about a week and a half. And that was 7 years ago. You go to that community now, there's farmers markets, the stores that started selling a tabletop of fruit and vegetables, that's all they sell. They've converted. And their tiendas is with them across the community. So what we can do is create leaders from the bottom up. Right? And it can be in the participants, the people we've worked with who have become teachers. It can be with that CEO who is working every day to change the structure of health in our community. And the thing that's really amazing, we just came across this in the data the other day, when we start across cultures, the health status of our participants are statistically significantly different across sites. When we end the program, for the most part, in indicators across mind, body, spirit, and emotion, that statistical significance disappears. So there is a place called health. It's culturally blind, and we can help everybody get there with health literacy. So don't be so doom and gloomy, please.
So I want to be sure that I have an opportunity to hear everybody who is still at the microphone. So if you could be succinct in your comments, we'll be able to get through that for the day.
Hi, this is Jim Doss with the Health Resources and Services Administration and member of the Roundtable. So I'm very glad that we created this space to talk about cultural competence, language access, and health literacy all in the same day. And I was also very glad to hear that there are examples in the real world where they are not siloed, and in fact there are efforts to make sure that they're all considered. And I think one of the things that we can do more of, and I think some of the presentations did start this process, is that if we look at this from the person's point of view, with a few case studies, how did the system that they are in, the health system they are in, how did that system fail them? But also, how did the health system help them be successful on a number of measures, whether it's for the condition that they came in for, but also on other measures. I think if we can tell the story on that level, I think then it'll become much easier to understand what systems can do, and it becomes, I think, part of the carrot to create some incentive for systems to change. And then I also want to thank Rima and others for the reminder that, when we're crossing cultures and trying to understand another culture, what's also important is that we understand our own. And that's also one of the messages from Ann Fadiman's book of, when the spirit catches you, fall down. So thank you.
I'm Jennifer Dillahay with the Arkansas Department of Health. So my reflection for today is, what am I personally going to do about this? So I have I guess you could call it a sphere of influence in my role at the State Health Department, and particularly with immunizations, but some other areas too. And I think this point about learning our own culture and learning about cultural competency and language access and what's happening in my own sphere is important, that I cannot afford to not be aware, and that if we're going to do well in immunizations in Arkansas, we need to do well in all of these areas. And so I need to redouble my efforts, make a commitment to make sure these things are, I understand them as a leader, and to encourage their integration and incorporation in all that we do. And there are other people at my agency working on them, and I can partner with them and do that. But, you know, it's a daunting task, because it means that I cannot continue doing the way I'm doing things now. I have to change. And so I will. Thank you.
Winston Wong, member of the Roundtable and from Kaiser Permanente. So we started off this morning with Dr. Androulis giving us a profile, a perspective of what in the post-ACA implementation era, these issues of LLC, and if one thing we can take away from today's summit is that acronym, what the opportunities are with LLC. And it did strike me that we, and probably the planners of this workshop, we need to come to the full grips of what the ACA offers us as opportunities and what it doesn't offer us as opportunities. For one thing, this country still has not really embraced the notion, the ideal, that healthcare is a right. And we have to understand that. If of the 35 million people that were supposedly uninsured prior to the passage of ACA, only 11 million have been insured under expansion. That means that 20 million folks have been effectively shut out the door. And the connection between the fact that we still don't, in this country, have embraced the notion that healthcare is a right enables us to rationalize why people who enter into the healthcare system can face a number of challenges in terms of accessing care, because it is viewed that you getting healthcare is basically a privilege. And anyone who comes into a system and says you're privileged to come into our healthcare system has no right to expect certain things. So fundamentally what happens is that if you have a physician or a healthcare system that is indifferent, that is disrespectful, that is dismissive, that is callous, well, you just better be happy you got something at all. So really the question is, if we expect the system to be providing you care with dignity, providing you care with respect, a caring system, and a system with empathy, we need to be able to be deliberate and forceful about creating a narrative that says healthcare is a right. And healthcare as a right fundamentally means that we can appeal to the underlying decency of Americans with regards to saying people need to be treated in a way that enables them to have the full fruits of what a first-class healthcare system can provide. So I think there's a lot of work to do around the narrative and have a consistent voice with regards to how these things really express themselves. We're actually, all the things that we deal with didn't happen by accident. They happened because of an ideological framework that rationalized the behavior that we see in the systems. So that's what I took away.
Mike Wolf, Northwestern University, member of the Roundtable. Brought to you a concept of nesting dolls, suggested the idea that health literacy might be an outcome, started to use the word business case, so I'm going home with lots of rejection today. Thank you, Lindsay, for hanging in there. And actually, just as a disclosure, I even suggested that the analogy wasn't working for me, but I framed it in quality. Always frame it in quality. So, I only have one point, actually, just for time's sake. And I don't know if anybody remembers what ARC used to do. Again, I feel like I'm coming away with a lot of maybe muddledness, which I don't want to get out of it. So I appreciated Andrew's kind of, let's stick to something that, you know, there's a lot of good. But ARC used to do something called the TRIP conference, used to stand for the Translating Research into Policy and Practice. And actually, it never really was necessarily so well populated, but the idea was if we're funding research, we want to know what happens to it. Does it have a legacy product that translates into some good that a health system, that something that sticks? And I remember Marianne Abrams at Iowa, you know, was able to really present some of the great work she had done at Iowa in health literacy and their health system. But I'm wondering if we can find a way to bring that back again, that we can have a means to constantly be collating and thinking specifically about what has become a legacy product throughout health systems. What are people like hearing about Long Island Jewish, what they're doing right now? I mean, all these things are, we want to know where's the evidence, because if we can learn not only on the implementation side how you did it, what it took to do it, and really that roadmap of getting into it, and also what type of outcomes and evaluation you got in place, it might help make the sell a little bit easier for some others. So I think there's a way to maybe rehash how that kind of TRIP model might be a means for us, even if it's segmented in these three topic areas. So again, thank you.
Hi, thanks. Steve Rush, United Health Group Roundtable member. The comments of my own. I'm reminded through the stories this morning of my internship in a rural slum where I was providing therapy and counseling to people who lived in that area. Lots of things, lots of stories. We talked about the concept of creating narratives and telling stories and letting people know how things have changed or how people have changed as a result of certain interventions. I think we need to continue that, but I think we also need to think about creating the business case. As you change the healthcare system, there's lots of dollars that have already been sunk into a system. For example, computers and data gathering and so forth and so on. In order to change that, in order to change that battleship, that aircraft carrier, the direction of that takes a lot of money, and it also takes stories. So if we can create some sort of business case which creates dollars, or talks about dollars, talks about how things have changed for people, then I think we will be more successful. Thank you.
Michael Pash-Orlo. I had a whole idea of what I was going to say, but then Winston spoke, and I realized that I was completely in the wrong space. And, but so thank you so much. Before I say that, I'm going to say my new favorite TLA, three-letter acronym, is LLC. Okay, so now you have two new favorite TLAs. Okay, so no, I do think there's a philosophical problem. We do have to talk, unfortunately, about this business case because we haven't resolved the primary issue that that we haven't agreed that this is a right. In several of our states, if you want to get treated for Hep C, commit a felony, you go to jail. Then you can get health care, but otherwise you won't be able to get it. And so it's bizarre scenarios that we're looking at. It is striking how much work there is to be done, even some really basic things. Because I'm using a rights framework in my mind, it seems obvious that you should be able to have language-appropriate services, and that you should have culturally competent care, and that you should have care that supports your health literacy needs and removes barriers in that arena as well. I think that it's a fabulous idea to think in a forward-thinking way about how to break the silos between these research areas. However, I think it's largely happening because some of those other groups are so weak and underfunded that they are going to join us because we actually have some momentum. So unfortunately, we have to keep that up. It's going to take a lot of work. The program announcement on health literacy has to be reauthorized at NIH. It's not a fait accompli that it will happen. Last time it happened, several of the institutes dropped out of it. And so we should be quite aware of what's going on and which institutes are available for this and which are not, and why that's the case. Some of the organizations that have been advocates all along have been dropping out of those funding. So even as though I think that the brand is strong, I also think we have to be vigilant and wary.
Hi, Dr. Lynn Ostrowski. I'm with the Aetna Foundation and a new Roundtable member with you, so I think we were probably peers in that. A number of things that you all said really resonated with me today. In particular, when Dr. Wolf talked about the point of care support to navigate the needs of the patient in the moment. I think that is such a doable thing. As you know, the Aetna Foundation is very focused on technology and advancing technology to reach a status of health equity of our populations. And so I think there must be some strategy that can allow that to happen in real time. And I'm hoping some entrepreneur actually brings that to the table. He also spoke about the importance of the nonverbal communication. I think we often forget about that. And the higher percentage of our communication is not our words, it's our body. It's you know, if our head is tilted, it's the inflection of our voice. It has absolutely nothing to do with the words that are coming out of our mouths. So I think that's really important in this whole discussion and should not be missed. And then I also, there was another gentleman that spoke about we need to treat people holistically. We can't look at them, we've carved them up very nicely here in the Western, you know, part of our country. The mouth isn't attached to the head, which neither's the brain, evidently, for behavioral and mental health issues. And we just do, you know, the shoulders down. So I do think that we have to really think about people as whole beings. And that brings me to, you know, really looking at the social determinants of health. And Michael, to your point on where's the anger, I think it's where's the outrage that we can have two communities 3 miles apart, and I'll use Roxbury, Massachusetts, and Back Bay, and we have Roxbury living a life expectancy of the early 1930s, right? People's life expectancy is 59.3 years of age, and 3 miles or so down the road in Back Bay, the average life expectancy is 91 years old. That is a huge issue in health equity and should not be tolerated. Yet, we're walking by people. People are walking in and out of these neighborhoods by each other with no realization of what's happening, and that's due to the social determinants of health. So I think that no matter what we do, unless we address those and have a, you know, really a conforming of the public health and the medical field coming together to address all of those issues, we are not going to get at undermining this health literacy and language assistance and culture. We've got to bring those two things together. And then lastly, I just had this thought of several years back, we in the United States made a change to medical professionals coming into our country from other countries and what degrees we'll accept and what level we'll allow them to practice at. And we've become extremely restrictive in that. And we are causing some of our own problems by not looking at those policies, not looking at those regulations, and allowing those people to practice here in our country. Perhaps there's a way of fast-tracking that, but they can't afford at their ages to redo medical school, redo residencies and fellowships. Yet we have this population here in this country that are living here that aren't allowed to practice, that are reflective of our populations. So is there something that we may be able to do to fast track, perhaps, those professionals so we can have a medical system that is reflective of our overall population? Thank you.
So I have a comment from Maren Allen, NIH Office of the Director. Maren is also a Roundtable member. She says, I miss being with you in person, but even from this far away has been a terrific meeting. One question I hope we talk about tomorrow is an example of what an ideal transaction in a full system that works and weaves all three of these threads together, what that looks like.
That's a good summary. So I think that everybody's comments, everybody's reflections really are worthy of further discussion. I think everybody put into words not only what was said, but what they thought was said that was worthy of further reflection. I didn't hear a unified theme. I didn't hear a unified focus, and that may not be necessary. It may not be necessary to have done that in the reflections we've heard today. I didn't hear pessimism at all. As a matter of fact, my thinking was that there was commitment and optimism going forward as to what we could and could not do to make a difference in terms of the comments of today. I think what I'd like to do is start tomorrow morning with a summary of what I heard today that could be connected to the mission and the vision of the Health Literacy Roundtable, which is really to implement and to change health care throughout the country. I think many of the comments will lead us in that direction and perhaps lead us to do things that would be helpful. A couple of things that would perhaps begin that discussion was Rob's comments about a true action agenda, and he tried to put that in words. And we do need a true action agenda that will enable us to do what Winston wants us to do, and that is speak with a consistent voice. So if we had an action agenda that we agreed upon, that we could actually have a consistent voice to act, I think we would make a difference in some of the comments that I heard around the table a short while ago. I will start off with that in the morning and try to put together some thoughts that maybe could carry on some of the comments that were made over the last half hour, 45 minutes. But this was truly a wonderful discussion from the morning until now, and your reflections bore that out. Because if we look back at what we were saying at the last meeting, I think we have many more new ideas that will enable us to focus on some of the activities that we would like to accomplish. So I think today was very successful with that in mind. We do have 2 buses that are leaving. I think one is leaving at 5:30. Correct me if I'm wrong. 5:15, which is about 6 minutes, and the other one at 5:30. So we will get ready to make that bus, and I think dinner is at 6:30. Thank you very much.